good evening. On the occasion of International Women's Day,
I welcome you all to the exclusive talk show on breast cancer, an initiative by Integrated Health and Wellbeing Council in association with Cipla Limited.
I'm Riddhi Lakra, Assistant Editor, IHW.TV. According to WHO, in 2020, more than 2 million women were diagnosed with breast cancer, and nearly 0.7 million deaths were reported globally. Breast cancer now has surpassed lung cancer as a leading cause of global cancer incidence in 2020, with an estimated 2.3 million new cases, representing 11.7% of the cancer cases. In terms of the mortality, 37.2% of the women died from this disease in India in 2020. The mortality rate in India is higher than an Asian rate of 34%. The high mortality rates with breast cancer in India could be related to late diagnosis, which is primarily due to the lack of proper awareness and the absence of screening at the risk population. The good news is that the breast cancer is curable if detected early, but due to the various underlying factors, there is a mismanagement of cases leading to premature deaths and fatality. Owing to the lack of awareness on the symptoms and proper disease in the absence of the breast cancer screening program, the majority of the breast cancers are diagnosed at a relatively advanced stage. To know more about the breast cancer, I welcome you all to this very timely session on saving lives from breast cancer. Know your body to save your life. Today we have with us Dr. Neeti Raizada. She's a Senior Director, Medical Oncology and Hematology Oncology, Fortis Group of Hospitals, Bengaluru. We also have with us Dr. Jyoti Bajpai. She's a Professor of Medical Oncology, Tata Memorial Hospital, Mumbai. We also have with us
Dr. B.K. Smruti.
Dr. B.K. Samruti is a Senior Medical Hemo-Oncologist at the Leelavati Hospitals and Research Center, Bombay Hospital Institute of Medical Sciences. Last, we have with us Dr. Ramesh Sareen. Dr. Sareen is a consultant in surgical oncology, Indraprasth Apollo Hospital, New Delhi. I welcome you all for this panel discussion. Dr. Neeti, I would like to start with you with a very basic question. In India, how common is breast cancer, and what are the different types of breast cancers we see in India?
Thanks, Riddhi, for inviting me today. Thanks, Hemani. I would like start by saying that breast cancer in our country is the most common cause of cancer when you even combine both genders, that is men and women. And when you look at only women cancer, it forms 1/4 of all women cancer. So 26% of all women cancer is only breast cancer. And till a decade back, we used to see a lot of advanced cancers. We would see, 60 to 70% would be advanced cancer. But now, because of awareness, because of it is widely read and spoken about, well, we also see incidence of early breast cancer.
Dr. I want to ask you this. We see a lot of patients coming in, but they are not aware about the different types of the cancers. So are there any specific classifications that the women should know, or maybe towards once it's been screened, then they can know about the types of the cancers? What is it like?
Breast cancer is divided into 4 main types, and basically it's dependent on the expression of certain proteins which are called as receptors on the surface of the breast cancer cells. And these are, basically what we call as estrogen receptor and progesterone receptor and the HER2 receptor. And also a marker of how quickly the breast cancer cells divide, which is called as Ki67. So based on these reports, which are included in the pathology report, the breast cancers are divided into 4 major types, like what are called as luminal A, B, and the HER2 positive, and what are called as basal or triple negative. So these are the main subtypes, and triple negative, which is less common in the West, it constitutes almost about 20 to 25% of breast cancers in India. Of course, the hormone receptor positive, that is ER/PR positive, is the most common type. So, and the HER2 positive is around 20%. So that is the different types of breast cancer and the constitution as regards, the overall breast cancer types.
Dr. Jyoti, coming to you, this is a very important question, like in terms like a lot of women do ask that what is the time that one should go for the screening of breast cancer. So when exactly should the screening of breast cancer start? What is an early stage? Are there a specific time once you see the symptoms? What is it like?
So thank you very much for bringing this important question. And I would say that one should be really vigilant right from the beginning about one's own body. And breast awareness is very, very important. So the women, they should be having a habit to examine themselves and also compare, both sides of the breast in a mirror and look for any kind of asymmetry, any kind of distortion of nipple and discharge, etc. And if there is any untoward thing, they should bring into, clinicians' notice as early as possible. If you talk me about the proper, screening, there can be multitudes of ways, and also the screenings is applicable depending upon what is the infrastructure availability, which country we are residing, and it actually varies from developed to developing world. Because there are resources which are different, and even in developed countries at present, the mammographic based screening is debatable. This is beyond scope of today's discussion, but I would say that we should be promoting breast awareness and the simple measures, because we are in India. So simple measures like clinical breast examination by a professional, which is, Tata Memorial Hospital has conducted a large study, and we found that with professional, trained workers, even the primary healthcare workers, if they examine it appropriately, the clinical breast examination could reduce mortality and morbidity significantly. So the in normal course of 50 years onwards, women should start doing screening. If and with this clinical breast examination, if we are in India, and an opportunistic screening which can be done by mammography, if somebody is suspecting something, as you were asking, that how can we detect them early. And also with this, I would like to say that if there are in some families, there is a certain high risk cases which is running because of their hereditary, because of their many first degree relatives which are affected by breast or ovary or something like that, or some other high risk feature which is present. Then in these women, screening can be started early. So routinely we recommend for clinical breast examination. Opportunistic screening with mammography can also be done. In very high risk women, even MRI screening can be. So it varies, it depends upon several factors.
Dr. Neeti, I want to come and ask to you, as Dr. Jyoti was explaining about the various tools to diagnose, and self-detection is in the starting, and then there are other tools as well. Could you explain more what are the different tools which is now available for diagnosing breast cancer? And as when you compare to the other countries, in India over the years, has this changed? Are there more diagnostic tools to identify breast cancer early?
So Radhi, as Dr. Jyoti very nicely summarized, well, a rule of thumb is in your 20s, start self-breast examination. That self-breast examination could be monthly. In your 30s, start clinical breast examination, in which you go to a trained clinician who does a 6-monthly clinical examination. Now, in your 40s, because in our country, mostly breast cancer happens a decade earlier, and we don't have standard guidelines in the country. So I would suggest that from 40s, at least from your 40th birthday, start mammogram. It could be 1 to 2 years, but definitely after 50. But since we have 40 to 55 as one of the common age groups, starting at 40. Now, as also ma'am said, that there's something known as a high-risk screening. And high-risk screening is for patients who already have either a high penetrance mutation, or they have a strong family history, which makes them more predisposed to certain type of cancer, especially breast cancer. For those type of breast cancer, the screening is started 5 years earlier than the youngest member in the family. So if the youngest member was 35, we actually started 30. And there, the treatment or the investigation recommendations are different. We would want to do a clinical breast examination, a mammogram for older patients, but for other patients, we may also want to do a breast MRI. Now, there are newer methods in our country. Yes, and the implementation is a little slow. But yes, in bigger centers, we have 3D mammogram known as tomosynthesis. I already spoke about breast mammogram. There's molecular imaging in which we use radiopharmaceuticals. There has been a lot of talk about thermal imaging, but we have to still have good data to use it on regular use. And there's again a lot of talk about testing blood, that is known as circulating tumor DNA assays. Again, these assays are not standardized. They are evolving, but again, we need robust data before we can use it routinely.
Dr. Jyoti, coming to you, as both Dr. Ramesh and Dr. Samruti were explaining about the various treatment options. So I want to ask this, should the family history of a person be considered for a breast cancer treatment decision? Should, like, if a mother had a cancer, or maybe her aunt had cancer, so are those one of the factors to decide the treatment decisions as well? Are there any specific things to be taken care about?
So thank you very much, Siddhi, for bringing this question out. And I think it's very relevant that we should be asking the family history of a patient, and it is having bearing on how, shape up the complete picture. So, so in certain, so majority of the breast cancer I would like to mention are sporadic, 95%. 5% of them could be having familial or hereditary back. So among familial also, it's not essential that they are always are hereditary, but at times they are having hereditary kind of breast cancer. So when we say hereditary kind of breast cancer, that means in this kind of family, there is certain abnormalities, which we call as mutational scientific language, are running, because of which the particular person is having high risk to develop cancer. I would like to give example of Angelina Jolie, which was which is a celebrity, and actually she has done a lot to increase the breast cancer awareness. And whenever I give some talk, I really say that she has done to increase breast cancer awareness so much that it is difficult to put together by even national awareness programs. So she was, if I'll give an example, she was carrying a BRCA mutation gene, and her mother and her grandmother, they both were affected with the gene. They both developed breast cancer, and eventually they had bad outcomes. So she prophylactically, because she was diagnosed with BRCA mutation, she underwent a bilateral mastectomy and later on reconstructions. So if such kind of mutation are present, then we are having multitudes of ways with which we can do either a regular interval surveillance, so that we can examine these women. So at present, these family members or these women, they are not having cancer, but we can keep them on high risk screening measures. So what we were just before discussing about, so we can regular intervals, we can meet them, we can do periodic surveillance, we can do MRI based screening, or even at extreme measures like bilateral prophylactic mastectomies, which can reduce the incidence of breast cancer substantially. Similarly, because these BRCA mutation genes increase the incidence of other cancers like ovarian cancers. So once a woman's family is completed at somewhere around 35-40, we also tend to advise them for prophylactic oophorectomy, which again substantially decrease the risk of ovarian cancers. So this could be another measure. Then there are also options of giving them some chemoprevention drugs like tamoxifen, etc. So because there are measures which are available to decrease the risk of such careers, I would not say patients. And even if a woman is diagnosed with one kind of cancer, and if she is having this kind of abnormality, she is prone to develop another cancer in her lifetime, either with another breast or similar or same side breast or ovary, and so on and so forth. So that's why family history is very important. But just because a cancer has happened in family doesn't mean that it is essentially hereditary. We have to differentiate. So there are certain criteria. For example, what are the numbers of first degree relatives which are affected? What are the number of second degree relatives? Is there any male member which is having this kind of cancer? And we should send them to proper genetic clinics for proper counseling, pre-test counseling and post-test counseling. And without counseling, just getting diagnosed with some abnormality can make, can develop a lot of agony in these, person's lives. So we have to be very, very vigilant, and methodically this should be done. So history taking in clinics, and later referring them to appropriate genetic clinic and counselors. So this is the practice we are following in Tata Memorial Hospital.
Dr. Neeti, coming to you with my next question. Already Dr. Jyoti have explained some of the important the treatment options, but mine is like a more one is like what are the various systematic therapies which are available for breast cancer treatment? And I hope like over the years it has been changed, and now the results are much better. Earlier it was say 80 to 90, now I think it's 90 to 100% of the cure is there for the breast cancer. So if you could explain what are the various systematic therapies which are available for breast cancer?
So Riddhi, you're asking systemic therapies. And systemic therapy, actually what we do is every breast cancer, most of the time, especially less than stage 4, is treated with multimodality treatment. And that multimodality treatment includes systemic therapy, it includes radiation therapy, includes surgery, as Dr. Sarin has explained, and everything is done in a certain sequence. And this sequence depends on the 4 factors which Dr. Smriti very clearly mentioned. That is ER, which is estrogen receptor, PR, progesterone receptor, HER2/neu, the presence of any one of them or the absence of all the 3, that is known as triple negative, and the multiplication index or the proliferative index known as Ki67. We always see for a breast cancer what is a combination of ER, PR, HER2/neu and Ki67. Now for people who are HER2/neu expressing, HER2/neu is a molecule or a marker on the cell surface and which makes the breast cancer more aggressive. So HER2 positive breast cancer are very aggressive cancer, but interestingly, they have various newer treatment modalities which can nullify the effect or probably make them respond better. So we give biologic therapy known as anti-HER2 therapy, which can be given as single anti-HER2 therapy or dual HER2 therapy in combination with chemotherapy to reduce the size of tumor and then subsequently undergo, if possible, breast conservation or mastectomy, and subsequently whether radiation is required or not. So this is for HER2 positive disease. When they are ER or PR positive, that is hormone expressing tumor, after chemotherapy, based on the stage, they may also require hormonal therapy. Hormonal therapy vary whether you're premenopausal or whether you're postmenopausal, whether you're high risk of recurrence or you're low risk of recurrence. So hormonal therapy is given for several years, ranging from 5 to 10 years. It could be in conjunction with 2 drugs, injectable or tablets. There are certain new type of hormones also available like giredestrant, other than the standard like aromatase inhibitors, tamoxifen as well. Now these hormones are variously used, whether it is a non-metastatic setting or a metastatic setting. In hormone positive breast cancer, there's a new drug called CDK4/6 inhibitor, which actually increases the effect of hormones. So they are known as hormone sensitizers, which can be given again in non-metastatic setting if they're high risk breast cancer, or in metastatic setting when you give again in combination with hormones. So hormone can be given in adjunct to hormone sensitizers to increase the response. And hormone positive breast cancer are generally the cancers which respond extremely well. The third type is triple negative, when hormones are not expressed and HER2/neu is not expressed. So they are known as ER, PR negative, HER2/neu negative breast cancer. Triple negative breast cancer is generally a subset of cancer, which is about 20% of all breast cancer. It's considered again a very aggressive subset, which can often recur at a certain period of time. So treatment is again modified suitably to make it more stronger. So dose dense treatment is given. We also look for if there's any hereditary genes positive, in which we give PARP inhibitors if BRCA is positive, or any other high penetrance mutation is positive. In this subset, we also, in metastatic setting and even in non-metastatic, we sometimes also use immunotherapy, which is again new generation of systemic therapy. So we add immunotherapy if a certain marker is positive to improve the response. High proliferative index, if Ki67 is very high, are also kept in long-term surveillance, because these are the patients who can recur at a certain point in time. So we always have guiding markers to decide what is a suitable treatment for them. If an advanced stage has recurred after some time, then we sometimes even do next generation sequencing to find out, again, there were certain other markers which could have made our treatment more suitable or improved the results.
Dr. Neeti explained about the the treatment options, like, so what exact, and there's another option of treatment, which is the last thing, like what's a immunotherapy. So if you could explain what exactly is a immunotherapy, and is it applicable in all types of cancer, breast cancers, or is there on the basis of the advancement of the disease, it is being given?
So that's a very important question, because patients have now heard of it, and they very often ask you that can we receive immunotherapy? Now, to understand the basics, it's important to understand that cancer has the ability to suppress the natural fighting systems of the body, which is called as the immune system. And we now have drugs which can unblock this effect. So we have drugs which can actually activate the immune system to identify the cancer cells and then destroy them. And that is what immunotherapy basically does. And as has been mentioned by Dr. Raizada, that immunotherapy is now an important treatment option which is offered to very specific subpopulation of breast cancer patients. It's not applicable to all patients. So if you look at early stage breast cancer, that is stage 2 and stage 3, then these patients can receive immunotherapy, mainly the triple negative, that is before surgery and also then after surgery. Whereas if the disease has spread to other organs, what is called as metastatic breast cancer, then again for the triple negative breast cancers, if they express a certain receptor to a certain level, then it can be combined with chemotherapy. So these are the two instances where immunotherapy becomes an option for patients. So it's not for every patient of breast cancer. That is what I would like to emphasize. Now it is administered in a very simple way. It's like a 1 hour infusion at a certain interval, that is usually 3 weeks. And of course, there are certain side effects associated with this treatment as well. As you know, when the immune system gets activated, it can also act against some of the normal tissues in the body. So there are certain side effects also, though the percentages are small and can be easily treated, but you have to educate the patient and the caregivers about these side effects so that one can monitor for these side effects and treat them effectively when they occur. Side effects like diarrhea or skin rash. And then of course you have to monitor the kidney function, the liver function. You also have to monitor some of the endocrine functions like thyroid function and the pituitary function. So all these need to be monitored. The caregivers need to be also educated, and also ideally they should be carrying an identifier that they are on immunotherapy, because for any of these reasons they were to land up in hospital in other under some other faculties, then those people need to know that these may be related to the immunotherapy. So all this education is very important for patients who are on immunotherapy.
Dr. Ramesh, coming to you, my next question is about a very common thing which we see after any cancer treatment, and in breast cancer it is one of the common thing about the hair loss. That's a side effect of the entire treatment of breast cancer. So how can that be managed, and are there any new things to control the hair loss? And there's a therapy like cooling with the scalp cooling devices, can that also prevent or reduce the hair loss? So are these such kind of technologies are there to help women that they do not lose their hair during the treatment process?
Yes, hair loss is a major side effect of most of the chemotherapy for breast cancer, except for 1 or 2. I mean, hair loss is there. And so when they ask you, you do tell them that there will be a 80%, 100% hair loss. And the first, before we go to how can you prevent hair loss, is before you start your chemotherapy, you tell them there will be a hair loss, but it's a temporary hair loss. Once you stop the chemotherapy, the hair come back, and they come back the same texture and the same thickness and the same color. And that it's a question of 6 months to 7 months that you may be without the hair, and that there are very good alternatives available in the form of wigs, and lots of shops and lots of facilities have come up with the wigs available, natural hair, short hair, long hair. And we also advise them, if they have long hair, to cut them short and then cut them short, so that they don't feel the effect of total hair loss all of a sudden. So these are the advices which are more important than talking about how can you prevent hair loss. So most of the women till lately, till the last 4-5 years, have been advised and have been counseled about this, and most of them have accepted. And when they come back for a follow-up, we say, wow, look at your hair. And, it makes them happy. Now, coming to, there have been lots of advice, lots of inventions about if we can stop the hair loss, because that's the most important and the most grueling side effects that a woman has to undergo. The only reason she doesn't want chemotherapy is that I'll be having a hair loss. The rest of the side effects, all these medical oncologists have come up with great medications. So how can we prevent hair loss? Yes, scalp cooling has been in the air for the last 10 years. And it hasn't stopped 100% hair loss prevention. It does prevent to some extent. So instead of having 100 hairs, you may be having 50 hairs, and the 50 hairs have gone, or it takes a longer time for the hair to fall off. It hasn't become very popular because it doesn't prevent 100% hair loss, but it does. At the same time, with the hair loss, I just want to allude a little bit on to, there is a medicine called Taxol, which is almost always given as a chemotherapy. And there is something called peripheral neuropathy. The nerves become numb in the fingertips and in the toes tips. And for that also, I think they give cold compresses and cold ice. This one's put their hands in the ice, and so that prevents. So कहने का ये मतलब है कि अगर आप जहाँ जो आपका निकल रहा है कीमोथेरेपी से, the hair, उसको आप ठंडा कर दोगे तो वहां पे कीमोथेरेपी नहीं जाएगी तो आपका वो लॉस नहीं होएगा. So it's a question of just cooling your scalp and cooling your hands and cooling your feet to prevent side effects which can be disabling later on.
Thank you, Dr. Ramesh, for explaining that. Dr. Jyoti, you want to add to this, right?
So thank you. So very quickly, I think majority of things were said. I wish to mention that, from ages, there were measures which have been followed by women and the caregivers so that they should avoid preventing their hair loss. It is one of the dreaded complications. And as Dr. Sarin very rightly alluded, that many women are aversive to receive chemotherapy due to this. So initially there were penguin caps and there was some modification. Now there are proper cooling systems. So two of the systems are very common, like Paxman cooling hair systems and Digna cap. So we have used in Tata Hospital Paxman cooling system, with which we did a randomized trial, and we have shown that the most commonly used two drugs, anthracycline based and taxane based, all of our women with breast cancer, they use those kind of chemotherapies. And we have shown that our results were internationally comparable. So we could prevent these women to have, hair loss. Of course, as Dr. Sarin was mentioning, when we say we could prevent hair loss, it doesn't mean that 100% of the hair loss could be prevented, but more than 50% of hair preservation, that means they can camouflage. So from a distance, you will not be able to make out that they really are having that kind of hair loss, and which is actually able to maintain their dignity and moral quite high. So very, very important. So that kind of primary, success rate in alopecia or hair loss prevention, we could achieve in 70 and above patient who were on a taxane-based therapy if they received first of that sequence, and in more than 30% if they received anthracycline-based in the first instance. So we should appropriately counsel. And as madam said that, it is always, it is a little labor intensive, so that the appropriate cap fit is very important. That message I want to give loud and clear, because if there is cap which is loose at somewhere, there will be an air pocket, and there the woman will lose hairs. So it has to be snugly fit appropriately by a nurse practitioner or by a coordinator. And then continuously there has to be this coolant flow before, and there is a pre-cooling time, and there is a post-cooling time, and there is during chemotherapy. So these all small factors are very, very important. And with that, we can achieve a satisfactory prevention of hair loss.
Dr. Jyoti, I have another question to you, regarding a different thing. Like, so a lot of people say there's a genetic testing. So once they know that, like your family has a family history of maybe a BRCA mutation, so there is a genetic testing. So if you could explain what exactly is a genetic testing, and how easily that is available for people, and if a woman wants to test that if the father had a cancer or the uncle had cancer, so they also worry that they might also get cancer in future. So is it easily available, the genetic testing, and how easily can one go do a genetic testing for themselves?
So again, thank you for this question. And as I partly mentioned in my other response as well, that genetic testing is available, but it should be very judiciously used, and it should not be just direct testing. One should be appropriately counseled before and after. So, there should be proper genetic clinics. That is the best way. So I'll give a model example of Tata Memorial Hospital, that we have a genetic clinic wherein a team of, consultants and paramedical staff, etc. They sit together, and they come. When we send, for example, we send a breast cancer patient who's young and triple negative, there is some amount of family history also present. And even if it is not present in triple negative young patient, there is high chances that this might only be an index case. So we should refer such patients to genetic clinic. So if such patients are sent to genetic clinic, they do a pre-test counseling. First, they counsel them well. They should be preempt that what could be the results and how it will affect that person or the whole family. And then the test is done. So after the test, again, this genetic counseling is done. So, at times there is a mutation which is pathogenic and which is clearly visible. So that, for example, BRCA, I have given an example. And if that mutation is positive, then, the whole lot of other implications. So then we need to test the family members who are adult, who are more than 18 years old. So, for example, a woman who is now found to be positive with BRCA mutation, then it's our responsibility to call upon her daughters who are more than 18 years, her siblings who are more than 18 years. And this all will take time and logistic, finances, everything. So that part should be very, very clear. At time, there is a clear-cut pathogenic mutation and clear-cut no pathogenic mutation, which is relatively easy to understand and explain. But at times, I want to really put on record that there is a variant of unknown significance, which causes a lot of worry and agony in these women. What to do? Because even we are not sure what to do. So there is something which is seen in this test report, but we are really not sure about the significance of that. So that's why we call it as variant of unknown significance. And then, I have seen in clinics that many women, their relative, they are very much concerned about this finding, and this keep on worrying them for long. So that's why this must be appropriately explained before conducting any kind of genetic test, that there is a possibility that you may not found a definite answer, and there is some uncertainty which will begin. So how to deal with it? Because some people, they're very anxious by nature, they're already having that kind of problem running. So perhaps if they are not prepared, we should be very, very careful, in advising them. So without genetic clinical counselor, it should not be directly done. That is a loud and clear message. But it should be done when it is indicated and under appropriate circumstances.
Thank you, Dr. Jyoti, for explaining that. And I hope a lot of women would understand that genetic testing is not just like a normal test, what you do, like a normal blood test, to find out what exactly your future would predict about. So thank you for explaining that. Dr. Neeti, coming to you, in the same lines, as we were talking about the different side effects, another important thing is the fertility. A lot of women are worried about their fertility once they undergo the breast cancer therapy. So is there a relationship between breast cancer therapy and fertility? In future, would they also experience some sort of problems, or can that be like conserved, like how breast is conserved? There is also, they can save their eggs in the future. Are there options like these?
So, Riddhi, a very interesting question. Actually, again, I mean, initially I had mentioned that in our country, we have younger women who develop breast cancer. And these younger women have more aggressive cancer, sometimes triple negative cancer, requires to be treated aggressively. So when you ask me about breast cancer and fertility, I can address it in two ways. One is people who are undergoing fertility treatment and now they have breast cancer. There's a subset of patient, and that's a questionable subset, in which people who have been undergoing IVF or some hormone therapies and then they develop breast cancer. Not much spoken about and not much data in that area. But again, the second part of it is people who have had breast cancer and now they want to lead a normal life, because survivorship in breast cancer is the most. I mean, it's also the cancer which is most treatable, has highest cure rates, and there are many people who do very well after the treatment. So younger patients, based on the stage and based on what was the type of cancer, can be advised to have, they may choose to have a baby depending on the stage, whether 2 years later, 3 years later, 5 years later, or whenever. But when we are actually counseling a patient for chemotherapy, we always also have this discussion about fertility, in which we tell them what are the fertility preserving options, because they have a long life beyond cancer. And that time when they're actually planning to have a family, if a patient already has a partner, so if she's married or has a partner, then one method called as embryo cryopreservation is normally recommended, in which we harvest the ovum and we collect the sperm, and then embryo is externally cryopreserved for a period of various length of time. It could be years and sometimes even decades. And whenever she is planning to have fertility, that embryo can be reimplanted if her normal fertility does not recover. Younger patients can have spontaneous recovery of fertility, but you have an embryo cryopreserved so that you can use it for future need if required. There are other methods like ovarian tissue preservation, ovum harvesting, and cryopreservation, but these are normally not the standard methods. So what is normally needed is that have a preliminary discussion. If they have not completed family, have a fertility expert to discuss that. Embryo cryopreservation remains the standard, but there are a lot of other methods like ovarian tissue harvesting, ovum collection, all that also recommended. But always medical oncologist has to work in conjunction with a fertility specialist to discuss these options.
Thank you, Dr. Neeti. Dr. Samruti, I want to come and ask you my next question. We spoke about the various side effects of the treatment, but a very important question arises that what exactly is the survival rate of the breast cancer patients? And when compared to the Western countries, where is India today in this situation? Is there always a positive approach towards the treatment, and has it been taken in a very right manner, that the patient is also taking the treatment properly, and the oncologist and the entire team who is treating them, they also have been showing a like a positive, it's a both-sided thing, like the patient is also working towards their health, and the oncologist and his team also. So how do you think, like when compared to the other countries, we have seen the survival rate of the breast cancer?
Coming to survival in breast cancer, as has been mentioned by some of the previous participants, that it has dramatically improved over the years as a result of evolution of better treatments and better options for breast cancer patients. And speaking of survival, it depends on two issues. One is the stage of the disease, and secondly, what is the subtype of the breast cancer. So these are the two important factors which actually go towards determining the survival. So if you are talking of early stage disease, the survival rates have, as mentioned before, have reached 90 and even have crossed 90%, going up to 95% in stage 1, stage 2. And, even in stage 3, it is reaching very high. When it comes to metastatic breast cancer, that is when the breast cancer has spread to other organs, with the advent of very effective hormonal therapies, which are relevant for patients, as mentioned before, which have the expression of the ER and PR. These patients can survive very long periods of time. I have survivors who have crossed the 15-year mark with spread to various other organs. Then, of course, when you come to the population who have HER2 positive disease and the disease is metastatic, then there too you have got very good targeted therapies, or what are called as the biologic therapies. And as already been mentioned by Dr. Aizada, that there are many options available for these patients as well. And there are very new therapies which have come globally, which still have to be introduced in India, but I think very soon will come. And that also prolongs their survival into many years. And of course, for the triple negative, that is where all these receptors are negative, you too have got immunotherapy, and you have got certain other new drugs which are called as antibody drug conjugates. So all these are improving the survival in triple negative as well, although that is with metastatic breast cancer, but of course not to the extent that we see in the HER2 positive and the hormone receptor. So as I said, that when we speak to breast cancer patients, we should be very positive in our approach. We should make sure that they become positive in their approach. That is very important, because the way the patient approaches their treatment very much depends on that positivity. This positive approach should also be, understood by the caregivers. So overall, there should be a positive approach, not only in early stage breast cancer, but also when it has spread to other organs. And, this concept has to be, disseminated, and women should be made aware of this. Of course, as far as India is concerned, we have issues about the cost-effective approach and the cost of some of these drugs, especially when it comes to immunotherapy, and also some of the drugs which are available for the HER2 positive patients. So I think that is where the issue comes up, the cost of some of these drugs. Fortunately, as far as the hormone receptor positive patients are concerned, due to certain patient assistance programs and all, even the newer drugs have become accessible, and some of them have also been made by Indian companies. So the accessibility has definitely improved. But some of the issues about survival, our survival is inferior to what we see in the West, largely because of, as mentioned, the advanced nature of the disease, and secondly, the access to some of the important drugs. So that is where I would place, the concept of survival globally versus India, but still we should be positive in our approach.
Want to close this session. We had a very good, interesting discussion. I have some few points, so I will ask in a closing format, like to each and everyone. Coming to first, Dr. Jyoti. Dr. Jyoti, your closing remark, and also, what do you think the importance of role of supportive care in breast cancer management? If you could explain that, and also your takeaway point for International Women's Day on breast cancer.
So thank you, Riddhi, and indeed it was a very interesting, session. You conducted really well and asked all the important questions. So I would say that, in today's world, I would like to give this message very loud and clear to all our, women colleagues and friends and patients and survivors and their families that, we have had so much advancements in last few decades that not only we can increase the quantity of life, but we can also increase quality of life. So not only we can cure you if detected at well in time and with a good biology, but we can give you a very dignified life. The side effects can be very, very minimal if you are reaching to expert centers and appropriate hands. So please do not shun away. You give this message that you try to detect the cancer as early as possible. Today also we are seeing in Tata Memorial that patients are reaching in stage 3 in more than 50%, and many even in stage 4. So then we lose the window. So please get detected early. Please spread this awareness, knowledge, handhold other colleagues and friends and family, and bring them into centers of excellence as early as possible, so that we can do the best possible things in first treatment. Remember, first treatment is the best chance of cure and also to preserve quality of life. There are measures which are available, like I said, scalp cooling, breast conservation, many drugs combination, etc., which can decrease side effects. About the supportive care, very important. Many patients still feel that they will be having a lot of pain when they are on chemo, or a lot of vomiting, nausea, the quality of life will be haywire. So that is really not true. With kind of supportive care advancement, we have our patients. So I say that to my resident and my fellows, that our patients should not vomit. That should be our benchmark. And we are having several trials which are also going on with even supportive care. For example, olanzapine, one of the drug, which is when we add, it further decreases the nausea vomiting incidence. So it is having a side effect of sleepiness. So we are doing a trial with low dose olanzapine versus standard. So there are several of such trials to increase support or to enhance supportive care are running in academic institutions like Tata. And we should take advantage of those, treat our patients appropriately as far as possible, and give them a life. So give life a chance with best possible treatment is my takeaway message.
Thank you, Dr. Jyoti. Dr. Neeti, like your takeaway point, and also the role of nutrition and living a healthy lifestyle for a woman.
So Dr. Jyoti actually very nicely summarized it, but I want to just say that breast cancer, being the most common cause of cancer, also we have to remember has the most important and most largest number of survivors. It is the most treatable cancer, whether it is in stage 1 or it's in stage 4. The objective of treatment in stage 1, 2, 3 is different, and advanced stages is different. But at the same time, every stage of cancer of breast is treatable, and sometimes treatable with very basic treatment, including just tablets sometimes, or some very basic supportive care. Nutrition plays an important role in generally maintaining a good, healthy lifestyle, having obesity taken care of from very early age, like including your adolescents, including your teens, having good body weight. All these have a protective effect, not having addictions, having good fruits and vegetables in your diet with some form of exercise. These generally have protection against all type of cancers, especially for breast, ovarian, prostate, colon cancer. But also during treatment, nutrition is very important, in which you should have small frequent meals, try to avoid fats and red meat if possible, try to take supplements in the form of proteins, because your muscle mass may come down, and generally being fit by doing basic exercises, including pranayam, breathing exercises, and yoga is the general recommendation. So yes, a lot of weightage on supportive care, but basic understanding that it's a very treatable cancer, curable cancer, and even in advanced stage, the treatment is very simple and can extend the life without compromising the quality of life.
Thank you, Dr. Neeti, for joining and like giving away your points on how breast cancer can be treated and taken care of. Thank you so much, Dr. Neeti. Dr. Ramesh, coming to you, like we see there is your takeaway points on this entire session, and also like how if somebody has breast cancer, should they be worried about there are less treatments or there is no option? Your takeaway points, and if you could tell why people should not be worried about the treatment of breast cancer.
My takeaway points are that we still see women in advanced stages. As has been said by previous speakers, 50% of them come in stage 3 and 4, and that is not acceptable. In the West, the average size of the tumor is 1.5 cm. And here the average size of the tumor is around 4 cm. So we need to bring down the size or the stage of the disease. And that can be done only by awareness and early screening methods that you have discussed earlier on. Also, one type of breast cancer that has been alluded to, ER/PR positive tumors. If you come in early, stage 1 and stage 2, with no lymph nodes or limited lymph nodes, you can avoid chemotherapy. There is a test that can be done, especially in postmenopausal women, which can say that chemotherapy will not work. You will have no side effects, no hair loss, no other coming to the hospital, the cost, the finances. So if you come in early and you are ER/PR positive, which 70% of the women with breast cancers are, they may not require chemotherapy. So that's another point which can be sent across to the women at large, that coming early will save your breast, will save your hair, will save your life, will save your finances. So the message is, if you have any early signs that Jyoti alluded to, come and have a consult with the doctor. The second takeaway point, which I think besides all medical advances, is that we have to give them counseling. The women's all said and done, all saying that you will live 90%. They have to undergo chemotherapy. They have to look after their finances. Sometimes they don't have the money. The antibody treatment of Herceptin and the other antibodies are to the tune of 5 lakhs a month. It's not easy. It's easy to say that, but how many can afford it? So, so you got to look after their mental and their home and their counseling, and keep giving them counseling from the time they come to your clinic first time, and sift the patients who are really mentally unstable because of whatever reasons, and send them over to the counselor or to the psychiatrist, because you do need them have peace in mind while they are taking the treatment and after the treatment. And lastly, but not the least, I tell my patients these days that next time I want to see you, I want to see you with 2 kilos less of weight. So weight reduction, especially if you're overweight, prevents cancer recurrence to the tune of 20-30%. I mean, we talk of chemotherapy, reducing it to the tune of 20-30%, and you're just reducing weight. So I tell them, walk, 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 walk. And so, I mean, there are coming early, looking at your lifestyle, and having counseling by the doctor who is treating you, or the counselor or the psychiatrist, will go a long way in giving you good physical, mental, emotional health if you have breast cancer.
Thank you so much, Dr. Ramesh. Dr. Samruti, coming to you, your takeaway points on this session, and also a message to all the women on International Women's Day.
Well, at the outset, I would like to thank you, Riddhi, for that excellent moderation of this program, and addressing the very important questions that come to mind for women who are faced with breast cancer, and also for women who do not have breast cancer, and making them aware that early detection is very important. So I think this program goes a large way to actually drive out many of the misconceptions that women harbor as regards, trying to detect the cancer. They're just scared of coming for screening because they feel that they would not like to know that they have it, So I think this awareness program is very important from that aspect. Now, my main messages are, it's all been said by all the other, my colleagues. I would just like to emphasize that remember the adage that stitch in time is very important. So as far as early detection is concerned, I think that has to be brought home to every woman. Second point is that even if it is detected, the treatment has evolved so well that there is every chance that women are cured, especially with early stage, and even with advanced stage. They have certain important treatments which are becoming more and more available to us, and these can, give a good quality as well as quantity of life. And the third important thing is there are very important aspects that women are multitasking all the time, and those who are faced with breast cancer treatments and having to face so many issues regarding the treatment which have been highlighted during this program, supportive measures are very important, and also the family support is very important. There are a lot of issues regarding family life, sexual life, which need to be discussed, and they need support from all these aspects. So I think this is very important. And the third important thing is changing the lifestyle, not only for patients with breast cancer, but women in general, eating healthy and exercising. Physical activity is very important, and keeping the weight down. So all these things are extremely important, and educating women and breast cancer patients regarding this, I think, form the pillars of success of treatment. And I always tell women that faced with breast cancer, or trying to get it detected early, that you have to face it and come to your toes and heels, but not to your knees when you deal with cancer. I think that is very important. So this is my take home message to all women on this Cancer Day.
Thank you, Dr. And I'm sure, I'm pretty sure that people who are listening to you would understand that, as you said, you should not go down on your knee while getting treated for the breast cancer. Thank you so much, everyone, for joining us. On behalf of the IHW Council, I would like to thank you all for taking time for this important discussion. And my special thanks to Cipla for supporting this initiative. On the occasion of International Women's Day, we pledge that we create more awareness about breast cancer and such initiatives to create awareness about the disease and the treatment. Thank you again, everyone. Have a good day.